Good afternoon, everyone. Welcome to November office hours. It is our final office hours of the year. Glad folks could make it. I know we have folks still logging on, but I thought I would get ourselves started today. We are recording this as we normally do. It'll be available on the HI Training's webpage in the near future. Can folks hear me okay?
Absolutely.
Excellent, thank you. And I see there's a response in the chat, so we know that's working. So as we go along today, if you have any questions along the way, feel free to ask, unmute yourselves and ask, or use the chat function. So we will get started. So we're going to have a presentation today through MVP, and then after that's done, we're going to talk about some policy and procedure updates. We're going to go over the comprehensive chart review tool for adults and children, some information on that, information on the data den rollout, our HCBS core workflow. We're going to talk about NetSmart updates and the QA performance improvement policy, some work we're doing around that, and then also the quality notebook. So we got a pretty full agenda today. But I thought we would start. We're going to introduce our presenter today. We have a presentation from Kim Ariel from MVP Healthcare, and she's going to be talking today to the network about the federal emergency waiver, and as that ends or comes towards an end, how we can better support our membership for Medicaid recertifications. So if you're out there, Kim, which I believe you are, I wanted to welcome you and thank you for attending today and presenting to the group. And then I'll also turn over the stop sharing. So if you have anything you wanted to present, you can pull that up on your end.
Thank you so much. Yes, I'm happy to be here and nice to meet everybody. Just a little background on me. I have been with MVP for 22 years. Started off in enrollment and billing and then worked into sales and recently took over as leader of the retail outreach team that specialize in government programs. So thank you, and I am looking forward and hope that I can figure out how to share this, so please bear with me. I'm not that familiar with Zoom.
There should
So
be
let's
either on the top or the bottom a
yes,
share,
let's
and
see if that
then
works.
hopefully from there. Oh, it looks like it's starting to come. Here you go.
All right. That's always a plus. So let me just move you guys over here so I can see everybody. And please feel free if there's any questions while we go over this, please stop me and let me know. All right, so we're going to talk about the public health emergency and not if it's going to end, but what's going to happen when it ends. So, my team does government programs. They specialize in managed Medicaid, Child Health Plus, HARP, and the essential plans. They also do off exchange, but this is their main focus, as well as Medicare and our dual special needs plan. So we look at the service area, and these are the areas that we have managed Medicaid, Child Health Plus, HARP, or the MVP Harmonious Healthcare Plan, and the essential plans. So looking in the area that I believe a lot of you are in is probably up in like Warren and above. Am I correct?
Yes, yeah, we're the
Perfect.
most northern part of the state, 8 counties. So Warren, Saratoga, and Washington would fall into
Washington?
that. Yeah.
Okay, awesome. So what is going to become the new normal? The public health emergency, like I said, is going to end at some point. We just don't know when, right? We just know that they're right now they've got January 31st of 2023, but it has changed a couple times just in the last few months. So our we want to overcome any type of obstacles that could potentially happen. We know that we have an enormous task ahead of us because during the pandemic, the eligibility for government programs and Medicaid were kind of set aside as people sought more assistance. They when the public health emergency designation expires and the pre-pandemic rules are reinstated, providers may have to address a large population where they have to recertify or have redetermination of their benefits. So one of the things we look for as a team is to kind of try and partner with that and help any way that we can to make it easier for the members. So we can work closely with your team. We'll make sure the transition to the new normal is handled efficiently, empathetically, and equitable. I can't say that. I'm so sorry. Clear eligibility backlogs, with many new enrollees in Medicaid and other programs, the efficient verification and recertification of beneficiaries is essential. And we want to communicate clearly, quickly, and compassionately to the patients and the upcoming changes. So we know that there's going to be a lot of people that unfortunately are going to not watch their mail, they're not going to watch their emails, and possibly could come into doctor's offices or hospitals trying to get services, and they may find out at that point they don't have coverage. We want to try and limit that and make that as little effect as possible. So we've got MVP has a large campaign that we've got along with New York State of Health to not only send blast emails, send text messages. So if everybody makes sure to keep it in the front of the members' minds, right? We want to make sure that the patients are fully aware when the public health emergency ends and what is going to be required by them to recertify and have their benefits redetermined. So, one of the things we want to keep in the patients mindful of is to make sure that they're signing up for those text messages and email notifications, not only with New York State of Health, but also with MVP. So, one of the things that we have been working on and we have seen a lot of benefit to is on-site collaboration. So, the picture here actually is one of my reps at a provider's office. We tend to go we tend to set it up for like 1 or 2 days a week depending on the needs of the practice. And normally it's anywhere from a 3 to a 5-hour time span. Obviously, if it's something that we feel could be more beneficial for us to be there longer or more frequently, we can also work on that. But we've seen a lot of success with this. It kind of puts us in front of the members, so it keeps them mindful when they see us. Oh, yeah, I got something that says I need to re-enroll or I need to recertify. So we've with a lot of the providers' offices, we've set up a plan of addressing that by, again, sitting in the offices, in the tabling at the providers' offices, or even just events out in the community to keep us in the forefront. We're there to answer any questions when the members come in, if they need to have it looked at as to find out exactly what day they're going to be need to recertify, or if they need to check on their benefits, or if they need to check and just see if there's a specific date assigned to them when they have to recertify. So, what we've seen as a best practice is we also work with the providers and leadership to have monthly and quarterly meetings with sales, marketing, provider relations, and the practice leadership, finance, billing, registration to discuss any results in the membership. So we keep when my reps are in the providers' offices or in community events or they're tabling at potential food pantries. If we get leads from there, we have reports that we can generate that shows specifically we got 50 enrollments from Glens Falls Hospital, or we got 5 enrollments from Glens Falls Hospital, or we haven't seen as much enrollment as we want to, or we haven't had a lot of questions. We also can provide lunch and learns. Why we're on site, why we can add the value to the providers, the patients, and the staff. we're able to come in and provide those kind of lunch and learn sessions. We have provider centered community events. We go to vaccine clinics, back to school events, baby showers, car safety events, holiday events, open house. We've a lot of, especially in the fall, we did a lot of the back to school events, which was great because we got to meet a lot of the families, be there to answer questions for the parents. We also can set up desired start date and hours. We, as early as possible, hours, we have any day of the week that we can look at working with you. We have mornings, we have afternoons, and it can really be identified what works best for the practice and your members. Is there any questions on that I might be able to answer? Anything that you think I might have missed?
I think, Kim, this is a great service that MVP is providing. Are you when you put out your schedule? This is Travis, by the way. um, when you put out, do you put out like a schedule to different provider associations when you're going to be at certain events so they know in advance? Um,
Absolutely. We have what we call a site flyer that once we get a schedule down, we will send the provider's office a flyer that they can post in the facility to let everybody know that we're gonna be there. They can also, if we do, a lot of places do like once a week or once every 2 weeks. My rep, if they're going to be in the office and we have a schedule, we can also set up appointments for members to actually come in. Let's say we're doing a weekly and we do a Tuesday every week from 9 to 12. We can, the rep can set up appointments the week that they're in there. It may not work for one member. They may not have all of their paperwork. They may not have their ID cards. They may not have all the information they need. They can set up an appointment for the following week where it would be a one-on-one with that rep and that member.
okay, great. The reason I ask is we have a couple of programs through AHI, and in particular, I mean, our internal care management agency does community engagement type events. So that could be information that could be handed out while we're at those events. We also have through our East program, I think there's some folks on representing that program as well. They do a lot of community based events, Saratoga, Warren, and Washington counties that could help to spread the news on that as well. As you know what that schedule is going to be and when. And I also put out there for our whole networks. I know this is only a portion of the network that MVP covers currently out of the 8 counties we work with, but a lot of the strategies that Kim had mentioned would be applicable to anyone that we support, no matter what managed care organization that person may be falling under as far as insurance. So we could help work with you and your organization to try and link to that particular MCO to see what type of strategies they may have to help assist with this recertification process as well.
Absolutely. And we can also, if there's community events that you have scheduled, we can also look at our schedule and see about tabling at that community event so that they're also getting to be more familiar with my reps and MVP in general. And it will help, again, keep it in their forefront of their mind. Oh, I see MVP. I know my recertification's coming. I need to start looking at that.
Yeah. And word on the street was that we were looking at the middle of January, the public health emergency, but now we're hearing that could be delayed potentially. Is that accurate?
It is, yes.
Yes.
They
Okay.
do have to supply 60 days notice.
Yes.
So, and that's one of the good things with the emails and the text messaging and making sure that people are signing up for those is because it can change. We've already seen it change at least 3 times in the last 6 months. So, um, right now, the last date I had heard was January 31st from New York State of Health. So if they're looking at changing that, we'll probably know any day. since we're looking at like the 60-day mark
Yeah.
next week.
Okay. Fingers crossed.
Yes.
Does anybody else have questions or any comments for Kim?
Right, well, I appreciate you all taking time to listen to me today and invite me, and it was great to meet everybody. And I'm here. If you have any questions, you can email me or you can just chat on the chat, and we will find out the answer if I don't have it.
Thanks, Kim. And Kim, do you have an email that you could provide the group in the chat just so they have that?
Absolutely.
Thank you.
You're welcome. I will stop sharing. Thanks, everybody. Have a happy Thanksgiving.
You as well, Kim. Thank you. All right. So that was nice information from MVP. And again, I think that'll apply across the network for whatever MCO the person may be working in or under as far as receiving insurance. So please reach out to the health home if you have any questions or anything around that. Kim, thanks for providing that email. Her email's in the chat if anybody has an interest to reach out to her with further questions.
Absolutely. Thanks, everybody.
Take care. All right. So we're going to move on. The policy and procedure. Jessica, are you out there?
Yes, I'm here.
All right.
Can you hear
So,
me? Okay.
yes, I can. So we're going to go over.
I get real nervous.
Oh, you're there. We hear you.
Okay, so we are going to be issuing the following policies for update. The newest version of these policies have not been sent out yet, just because we do have a batch coming and we wanted to send them in a group, but we did want to review what we had completed this month, so it will kind of lessen what we have to go over in January. So those policies are going to be the notice of decision, our non-health home policy, and our interpreter policy. Go to the next slide.
Sorry. Went way too far. There you go.
Okay, so our notice of decision policy, this was really updated just for an annual update, and then it was updated based on some feedback that we got at redesignation. So just some highlights of that policy is you want to make sure that when anyone is enrolled in health home, that they are being issued the notice of enrollment, so that DOH 5235. And what's really important is that the enrollment date is completed on this form and that you're uploading this document into NetSmart within 5 days of enrollment. In our audits, there were excuse me, a lot of these forms missing. So we just want to make sure that we're doing that. And then moving forward with our new categories feature in NetSmart, we will be able to pull a report to see who has one on file and who does not. However, that's a newer feature, so we won't be able to capture some of our older enrollments. Another notice of decision, just to review, no changes to it, is going to be our 5235, and that's our disenrollment notification. What's important to remember about this form is it is no longer required to be sent to everybody. This form is only sent to those who are being disenrolled from health home without an awareness of their disenrollment. So if you have a planned discharge with someone, you can simply send the disenrollment letter on agency letterhead, letting them know that they've been disenrolled from the program, the effective date, and that also all of their information sharing consents have ceased with their disenrollment date. If you're able to have a documented conversation with the member and hand out that letter, you do not need to send the 5235. This would be sent to those who are in disagreement with their disenrollment or those who potentially have gone into appended status due to incarceration or someone who has gone into diligent search that we weren't able to re-engage, and then subsequently in the 4th month, you need to disenroll them. What is important is that this 5235 should be issued and dated 10 days prior to the actual disenrollment in NetSmart. Next slide. The notice of determination for denial of enrollment. So sometimes we engage in outreach members, and once we do their outreach or their engagement, we realize that they are potentially not eligible for health home. That would be that they don't have Medicaid, and this could be that we wouldn't want to say, oh, you don't have active Medicaid, so we're not going to enroll you. We would link them to EASE to help them get Medicaid situated. This would be people who do not have Medicaid and would never meet the income threshold for getting and receiving Medicaid. Sometimes our members that we outreach to have Medicaid, however, they have an incompatible coverage code. And if that were the case, we could work with the member, we could work with the local department, but in the meantime, they would not be eligible for health home. If they don't have diagnostic criteria for health home eligibility, they don't have appropriateness criteria, they're already enrolled in another health home, or they reside in an excluded setting. These people would be denied enrollment into health home, and then you would need to issue the 5236 with the reason on this form, and then you'd upload it into their outreach record. Next slide. So what's important to remember is that the 5236 and the 5235 come with the right to a fair hearing. So if you are disenrolling someone from health home who is not in agreement or wasn't aware because they were in diligent search, you have to issue the 5235, or you deny someone enrollment into health home and you issue the 5236. Both of these forms come with the right to a fair hearing. So they can object to their denial of enrollment or their disenrollment from health home. On the back of this form, so anytime you complete this form, you obviously upload a copy, and that the member also gets a copy. On the back of this form, they would complete the right to a fair hearing that they have 60 days to request, and then they would send that in. We have seen people who are in diligent search, they get issued the 5235 and they simply call the health home and we get it worked out. But they do have the right to a fair hearing if you issue either one of these forms. Next slide. So there are a couple of notice of decision forms that go along with our children's population who are enrolled in HCBS. One of those forms is a notice of decision for enrollment or denial of enrollment. This would be anytime someone completes a level of care and is enrolled in the HCBS waiver, they'd be given the 5287, or if you complete the level of care and they come out ineligible for the service, they'll be given the 5287. This form must be completed every time a level of care is completed. So the initial and then every annual thereafter. If you have someone who is enrolled in the waiver and they become disenrolled in the waiver, they're issued the 5288, which is the discontinuance of the waiver. And that could be because they are ineligible. It could be because they no longer wish to be enrolled. It could be that they've gone into an excluded setting. So these are also two notice of decision forms that we mention in this policy, but there is a children's policy around these forms and disenrollment specifically. So for more information, you can refer to that policy. Next. Okay, did anyone have any questions on the notice of decision policy? Okay. Non-health home policy. This is for all of our members who utilize NetSmart to serve their non-health home population. There is no updates to this policy. It was just an annual review. So the current workflow is that if you want to enter someone into NetSmart to work with them in a non-health home capacity, you would complete the non-health home, or you would complete the care management referral form. And you would want to make it very clear on that form that they need a non-health home program. And then Courtney will upload that member's information into NetSmart, and she would put them in a non-health home program. And then you also want to make sure that there is some sort of consent on file that your CMA has with that member, letting them know that their information is being kept in the health home's EHR and that it is viewable by the staff at the health home. And then another thing to keep in mind is that a $3 PMPM will be billed for every non-health home member that is managed in the NetSmart EHR. Next. So sometimes we work with members who are being served as non-health home and then they become health home eligible. So you want to move them in out of their non-health home program and into a health home program. What you want to do is you want to complete that care manager referral form, and you're going to send that to Courtney. And then you want to make sure that it is very clear that the member is now eligible for health home and that they need to move from a non-health home program to a health home program. So you're going to submit that to Courtney, and then in NetSmart, you're going to discharge the member out of their non-health home program. Courtney will update the record. She'll include the SIN, and then from there on out, you're going to follow health home policy and procedure for that member. Next. Sometimes we have health home members that we are working with that move to a non-health home program. So sometimes for whatever reason, members are no longer eligible for health home, but your CMA can serve them in a non-health home capacity. What you're going to do is you're going to follow the health home disenrollment policy and procedure for that member. Then you're going to complete the agency referral form. You're going to send that to Courtney, and then you want to make sure also on that form that you are clearly indicating that this member is moving from a health home enrolled program to a non-health home program. She will update NetSmart and start a new episode to show that that member is now non-health home. Next. And then once we're working with any of our non-health home population, it's extremely important that you disenroll them from NetSmart. We need to make sure that our non-health home population remains up to date and accurate in NetSmart. That is how we determine who is in that population. That's how we determine which agency and that is utilizing our platform for non-health home, and that is how Courtney will submit the billing for the $3 per member per month for utilizing NetSmart. Next. Did anyone have any questions on the non-health home policy? Okay. The next policy we have is our interpreter services policy. There are no updates to this policy and procedure, except we have a new addition of a service. This policy is to be used whenever we have a member that we're working with and there is a barrier to communication regarding to language. We have the ability to utilize a service that helps with translation so we can work with that member. And the newest service that we have to offer is our American Sign Language service. That is going to be available through an additional platform. It's Language Link's video remote interpretation platform. So right now you would call Language Link. If you were trying to translate, let's say from English to French, you would just simply call the number. When we utilize the ASL service, it is part of Language Link, but it is a different platform. So if you have a member that you need to communicate with via ASL, you'll reach out to the health home, and then someone at the health home will provide you access to that service. Access to the VRI service will be provided by the health home to each requesting care manager on an as needed basis moving forward. And that's only for ASL. Everyone else will continue to utilize Language Link for the translation services as they always have. Next slide. And this is how you would access Language Link for all of the other services that they have for translation. You just follow these steps. And then the thing to keep in mind is if you do need access to the ASL service, you'd simply email the health home and we would provide access for that. Does anyone have any questions on the interpreter policy or anything we went over? All right. Well, if you do, you can always email myself or email the health home and we will get any questions answered.
Thank you, Jessica. We're excited about the American Sign Language edition. It's going to allow the ability for a virtual person to go on the other end and actually assist with sign language during the interaction with the member that you're working with. So it's pretty cool. So if folks come into that circumstance, please let us know and we will work with you for access. So moving on, comprehensive chart review tools. So we currently have those tools for the adult and children population up on our website and the additional forms link. We're going to be updating that link in January with some changes to these audit forms. They're not tools that you have to use, but just so you know, we utilize them when we do audits as a lead when we're doing the different audits for different organizations throughout the year. So we've added some different elements to these tools. They're going through final revision. Some are things that we wanted to add as a lead. Others were through the redesignation process. Some things that the state wanted us to add as well. So more to come on that, but just wanted to make folks aware that they are coming new and improved as of January. We get into data then. We began our rollout. We have 4 organizations that are live. We had a couple bumps in the initial phases, so we put a pause on for a week or so. We've ironed them out with our third-party vendor, and we are on track again to get back to it, to get folks throughout the network on and live. So we will be reaching out in the coming days, after we get through the holidays here. Through Thanksgiving and start to set up some timeframes to meet with your respective organization, supervisors, and team. So we're excited. We've gotten good feedback thus far for those organizations that have been able to get up and on and running, and we're looking forward to extending that to the network. So stay tuned. More to come. So now I'm going to start talking about the core workflow and HCBS workflow for HARP program. I wanted to go through this through our redesignation. It came up as an item to point out some things in the process, but also I thought since this new flow came into place in February of this year, some time has gone by. It'd be good just to address it again with the network so folks have the ability to hear it. I'm not going to go verbatim through each of these slides. I do encourage folks to look at the HARP policy, the Health and Recovery Plan policy for the adult program, read it in detail, but we do want to go through highlights and give opportunity for questions. So the first area I want to touch on is the actual core services and eligibility, and a person has to be part of the HARP program or HIV special needs plan in order to be eligible for core, and they also have to have recommendations by an LPHA, licensed practitioner of the healing arts. So those 2 elements would get a person into the core service realm. And then that LPA is a qualified professional. There's a whole list in the policy from psychiatrists, psychologists, physicians, nurse practitioners, et cetera, that would be applicable as LPHAs. And they would be the one that would be given that clinical recommendation. So that recommendation is based on their discretion, as I just indicated. There's not a standardized assessment criteria at this point, but the clinical discretion is there. There's a form that's recommended, the link I've provided to get folks to that form. But it doesn't stop a referral from happening. So if you don't have that form available, you can still move forward for a referral and get that process started. And it can be A recommendation can be used for one or multiple core services. So you can use a single recommendation for one or more. It doesn't have to be a separate one for each service. Referral process again for core, similar to a lot of other services for referrals. You want to identify the type of service to support that person. You want to identify the provider. You got to contact providers to make the referral. Providers' process for referrals may be different depending on the organization. You would coordinate with the LPHA recommendation if it's required or necessary. And then you would have that collaboration between a referral source and a provider. It's a best practice to do that warm handoff if you can, in most instances where you attend the first meeting or you assist the person on the first call, just to help get the ball rolling, for the fluidity of that for that person. Any questions so far as I'm going through the core? Okay, we'll keep going. Referral versus the LPHA recommendation. Referral can be made by anybody. The person themselves who are receiving the services can put the referral in. It's going to connect that person to core services. Every provider, as I mentioned, that referral process internally might be a little different, but it can be done by anybody. The LPHA recommendation, that's a qualified staff, as I indicated, that would be lined out in the policy itself within their scope of practice. And their form would be filled out designating the medical necessity for this service. And it's completed before or during that intake of the process for core evaluation. So then we get into HCBS workflow. If there weren't any questions around core, I was going to move forward with that. Any questions around core? Okay. So big thing with HARP HCBS workflow, I have highlighted in yellow here. Only members that are interested in the HCBS will need to receive the eligibility assessment. So it's not mandated anymore unless that person is interested. There used to be a 90-day time frame to complete that assessment. That's no longer the case. It's not static as far as when it has to be done. The face-to-face requirement is not required any longer. That can also be telehealth appointment to get that completed. And if a person does have that assessment and rolls into the HCBS, the eligibility assessment has to continue to be done annually, or as there's a change in that person's situation to have that continuity of care. And so that's a big thing. And there's two tiers under the eligibility assessment itself, tier 1 or tier 2, as you can see. And you can do it telehealth if you want. That's a nice thing. That was a big change that happened. Circumstances that a person may not pursue HBS after that eligibility assessment's been completed. They're found not eligible. Could be one. They're found eligible, but they don't feel the HBS will help them reach their role or goal. They're found eligible, but they choose to remain in the state plan service they're already getting. They're found eligible and reside in a setting that's not considered home and community based. So if that person were to switch to a different setting that was eligible, then that should be engaged again with the care manager to have that assessment completed. Some things to highlight here on this slide. If the person's not pursuing HCBS for any reasons that I had mentioned above on prior slides, that's going to be documented in the UAS platform as well as in that person's plan of care. So we got to make sure we document that. If they decline the assessment, that's got to be documented as well in the plan of care. So we got to make sure that we're documenting. It didn't happen if it wasn't documented, basically. And then if that person wants to receive a service that's not available in their geographic region, then they just reach out to the health home and we can alert the MCO of the gap in services. Excuse me. Any questions so far about HCBS workflow? Okay. So we get into the level of service determination. So that service provider submits that level of service determination request to the MCO. The MCO has 3 business days to review that and respond, but no more than 14. So that's a sliding scale, 3 to 14. But 3 days or no more than 14 of the date of the request. So, folks, another thing I wanted to note was that the person's got to be given a choice of providers from the network, and it must be documented in the plan of care that the choice was given to the person. So again, it's got to be documented, very important. Referrals, the 2 big things that I wanted to know on the referral process itself, the MCO level of service determination, the service provider makes a referral to HBS to the person's choice of provider, and that of course has to have the proper consent. And then the health home service provider is going to send that level of service determination with all supporting information to the MCO for the request itself to be approved. And then for the intake eval piece for providers, and once that referral has been received, the provider is going to notify and provide the MCO with the date of their initial scheduled intake or appointment. And then if this date changes, the provider must notify the MCO. That provider also has 3 visits with the individual within 14 days of the initial visit to evaluate for scope, duration, and frequency of HCBS. If more are needed, then that's got to be notification through the MCO. And then the continuation around referrals, the provider, HCBS provider, completes that evaluation, and then they request the MCO to authorize provide ongoing HCBS. The provider must submit the prior and continuing authorization request with the recommendation, frequency, scope, and duration to the MCO. At this point, the MCO reviews. They must inform that the health home service provider or the HCBS provider and the member of their determination. Now, when the authorization of scope, duration, frequency of HCBS, the provider must notify the health home service provider to add these elements into the plan of care. So you can see that the timelines are pretty straightforward. If you ever run into any issues with that referral process, please let the health home know, and we can help work through that with the MCO. And then the health home service provider completes and submits the HCBS plan of care to the MCO. Any questions on the workflow itself? Got to make sure the person signs a plan of care prior to submitting the completed plan of care to the MCO. And then once that's done and all the requirements been added, then that's got to be submitted to the MCO. And the assessment itself for a person that's been approved for services is good for a year, or unless there's a change along the way that would constitute doing the eligibility assessment again. But you have 1 year from the date of completion to do that assessment. Any questions before I move on? I know the HARP workflow process is never fun, but just wanted to take the time to touch on some highlights through it again. Okay, moving on. We got a quiet group today. NetSmart updates. So circling back on the comprehensive assessment, we had that new assessment going. There were issues we were working through with NetSmart. Those issues have been resolved. The issues were not being able to select multiple options or questions, not able to select problem type, such as behavioral, social, or physical, once the diagnosis was selected. And you couldn't select providers within the comp assessment itself. So those should be all remedied at this point. That's been within the last couple of weeks. So if you do run into any further issue, please let us know. But we're very hopeful and encouraged that they have been resolved. The safety crisis emergency plan continues to be an issue, saving that draft the final status, though. It is with NetSmart Engineering. We do apologize for the time that's going by on that, but they are working on it, and we're hopeful that it'll be resolved shortly. The NetSmart reports, we talked the last couple months about November, December being the 2 months on the new platform. Well, that got delayed. We were just informed in the last week and a half that that's been delayed for the time being. There's some negotiations going on between NetSmart and the platforms through the self-reporting server that they're looking to switch to, and they were able to get that extension. We don't know what that extension is at this point. But we do encourage folks at this point, if you have reports that you would like to continue to use, to make Taylor Dawson aware, and then we can see about incorporating or working with NetSmart on that. And if it's not a NetSmart thing, we could see if something we could do through Data. And we're just asking folks to include the title of the report in the email when you do reach out. Any question around NetSmart stuff? Okay. I wanted to touch on the quality assurance and performance improvement policy. We are in the throes of updating that with the rollout to the network January of 23. So this coming January, a lot of the changes are incorporating a lot of the quality initiatives we've been working on over the past year. Some through redesignation, some that were in the works prior. You see here listed Data Den, the quality notebook, a Health Home Plus report. I added in monthly office hours and a defined corrective action process. So these 5 things that I listed are things that are going to go into the policy as part of our quality performance policy itself. So they're tools ultimately that are being used. Part of quality is as we get to the monthly office hours organizational attendance. One thing we've noted, because we have a participation roster from each of our meetings that we maintain on organizations that have attended. And there have been a handful of organizations that have missed a number of meetings for office hours. We've never mandated it, but it's highly encouraged that office hours is attended because we go over a lot of information and a lot of it's relevant to the work that's being done in policy implementation. So we're adding that into our quality policy as one of our components that we look at as we're moving forward. We're also going to define our corrective actions process to a tiered process. It was written loosely up to this point. We would have a corrective action note in there and a performance improvement plan note in there, but there's no context around any of those 2 things. So we're defining that out further. And our first step in that tiered process would be the actual quality notebook itself. So that gets sent out monthly to each supervisor. There may be corrective actions depending on what the organization has in the notebook as far as follow-up, if any. In the event there are actions, there's always a time frame that the health home asks for a response. In the policy, it's going to be clearly defined on actions that would be taken as next steps if there was not a response from the provider, if there was one requested. And it's going to be clearly defined so that's transparent, for everyone as we're out there doing our work, and everybody understands the expectations as we move forward. So that's going to come forward in January. Wanted to mention it now so folks know that it is in the works. If anybody has questions and wants to talk now about it, we can talk to some extent. The policy still is under review. And again, we'll be training on it before we implement across the network. Anything around this particular policy topic that anybody wanted to mention or had questions around? Okay, will there be more to come? Quality notebook, we added another tab that folks are going to start to see specific to children's HCBS. It's all things HCBS, as Jessica would say. So it's really to assist our providers in monitoring, everything around HCBS for children. And it really stemmed from a lot of follow-up that was occurring through a number of emails and phone calls, et cetera, and questions. And this is our effort to start to help decentralize that into a spot where folks can see it in more real time and be able to respond and respond accordingly. Jess, I don't know if you had anything else you wanted to add around this particular tab, but it will be as we move forward.
Yeah, the only thing, as Travis said, we just wanted to add this tab to the quality notebook because there's been just a lot of one-off emails that go back and forth between myself and CMA. So
We got someone chatting. If we could mute, if we could.
So I just wanted to consolidate all those emails kind of into one tab. And since we already send out this quality notebook, I just figured it was easier to add this tab on there. I'll still email you guys. And if you guys ever have any questions or you have follow-up on something, you can always email directly. Email me directly. I just thought it would be easier if we just kind of consolidated some of the things that are going back and forth into one location in that quality notebook. So again, it'll be all things HCBS, like Travis said. So a missing form, a level of care that needs to be updated, a plan of care that needs to be completed, maybe even a question where something is, I can't find it. I'll put it on here. So every agency who serves HCBS children will have this tab added as things come up that I need feedback on. But again, if you ever have any questions regarding HCBS or anything in the notebook that you get sent, please email me directly.
Thank you, Jess. Yeah, we're really trying to simplify and hopefully make things easier for folks. And we're really looking at that quality notebook as that tool, along with Data Den and some of the other things that I've been mentioning around our quality policy. So that's why we're putting so much effort into it. There's so much administrative burden that falls on our care management staff and our supervisors and our administrative staff at each of the organizations. And it's a lot to keep track of. And that's just one piece of the job. Obviously, working with people is complex, right? We're not widgets. We're not black and white. It's very gray, the work we do. So, but the administrative burdens and it's a necessary evil, and we're trying to come up with ways to make that easier for folks in your day to day. So that's the goal ultimately. And then that was it for today. I will give one more update. Shelters of Saratoga has actually been approved with their MMISD number. They're going through their process right now to get their training completed on MAP and UAS and the HCS platforms, et cetera. So as they're going through that, we're looking at the early part of next year to likely do our onboarding training with the provider. We're excited about it. We'll have them start to attend our office hours as well shortly. We're still working with St. Joseph's Rehabilitation Center and People USA to get them through the process to get them on board as well. So exciting. We have another organization we're talking with that may be moving forward. So stay tuned, but we may have a fourth next year as things move forward. So the network's going to continue to grow. We're excited about that. A lot of people out there that are in need of services, and the more options we can provide, the better. So we're excited. And a big thank you. Did anybody have questions or anything they want to talk about that we didn't mention today? Anything? Our last show for this year. We'll be back in January. If anybody has questions along the way, though, please reach out to the Health Home email or give us a call, and we'll be happy to assist. And hope everybody has a great Thanksgiving and a safe holiday over this coming weekend. And thank you again for everything you all do. We greatly appreciate it. Take care, everybody.
Thank you, you too.
Thank you.
Thank you.